Hi, this is Veronica Hodges, coding instructor. We will discuss ICD-10 General Coding Guidelines. Please note that all guidelines can be found at www.cms.gov/Medicare/ICD-10/downloads/2016 ICD-10 Guidelines. It is very important that you reference ICD-10 coding guidelines as it tells you what to code, when to code, and how to code. Let's discuss locating a code. First, you must always identify the main term. Then reference the main term in the alphabetic index. Once you locate the main term in the alphabetic index, you will verify the code in the tabular list and read all instructional notes. Here again, it's very important that you locate the main term, locate the term in the alphabetic index, and reference the tabular list. Please review the coding guidelines for locating a code. Let's discuss level of coding for just a moment. ICD-10-CM codes consist of 3, 4, 5, 6, or 7 characters. 3-character codes are usually the heading of a category of codes that may be further divided by the use of 4th, 5th, 6th, or 7th characters. A 3-character code is to be used only if it is not further subdivided. Keep in mind that a code is invalid if it's not coded to the highest specificity, which means not coded to the required characters. So if a code requires 7 characters, you must code 7 characters. If a code requires 6 characters, you must code 6 characters. There are indicators in your ICD-10 manual that tells you to code to the highest specificity. Usually things are indented in the tabular section, and we'll discuss that more. Conditions that are an integral part of disease process. Signs and symptoms that are associated routinely with a disease process should not be assigned as additional codes unless otherwise instructed by the classification. Conditions that are not an integral part of disease process. Additional signs and symptoms that may not be associated routinely with a disease process should be coded when present. Now let's discuss acute and/or chronic conditions. I want to remind you that all of the guidelines are listed on the CMS website and are located in the front of your ICD-10 manual. Now, if the same condition is described as both acute and chronic, and separate sub-entries exist in the alphabetic index at the same indentation level, code both and sequence the acute code first. So keep in mind that the guidelines tell you what to code, when to code, and how to code. A combination code is a single code used to classify either 2 diagnoses or a diagnosis with a manifestation with a diagnosis with an associated complication. Combination codes are identified by referring to subterm entries in the alphabetic index and by reading the inclusion and exclusion notes in the tabular list. Only assign combination codes when the code fully identifies the diagnostic conditions involved or when the alphabetic index directs otherwise. Multiple coding should not be used when the classification provides a combination code that clearly identifies all of the elements documented in the diagnosis. Now let's talk about multiple coding for just a moment. Sometimes you may need to code more than one code to describe a condition or disease. Please note that you will see in your ICD-10 manual a statement that says use additional code. When you see that, that means that you have to use more than one code to describe the diagnosis or diagnoses. Please note that the secondary code must be added to code appropriately. For all of you that are coding for inpatient or taking courses for inpatient facility coding, let's talk about impending or threatened conditions. For those that are on the physician side, the prophy side, if you are learning coding from that angle, then please note that you must always code confirmed diagnosis. If you do not have a confirmed diagnosis, then you can default to the signs and symptoms, but you must always code a confirmed or definitive diagnosis in an outpatient or prophy side of coding. So for those of you that are learning codes or coding for facility, note that if at the time of discharge the condition is categorized as impending or threatened, if it occurred, code as confirmed. Code the confirmed diagnosis. If it did not occur, reference the alphabetic index to determine if the condition has a sub-entry term for impending or threatening, and also reference main term entries for impending or threatening in your alphabetic index. If the subterms are listed, assign the given code. If the subterms are not listed, code the existing underlying conditions and not the condition described as impending or threatened. So this is more so at the time of discharge, this particular guideline. As far as outpatient, like I said, outpatient prophy, physician side coder, you must always code the definitive diagnosis. If the definitive diagnosis does not exist, you will default to the signs and symptoms. Now let's talk about the same diagnosis on the same day. You only can report one diagnosis code per encounter. Now that applies also to conditions that are bilateral conditions. There is a lot of laterality in ICD-10, which means that there are codes that are appropriate for left or right or for both sides. Just make sure that you read and select the most appropriate code and know that you cannot choose the same code twice in the same day or for the same encounter. Now, let's talk about laterality more in detail. If the code specifies right, left, or bilateral, choose the most appropriate code. If no bilateral code is provided and the condition is bilateral, assign separate codes for both left and right. If the site is not identified in the medical record, assign the code for the unspecified site. Never assume. If you see that there is a diagnosis that could be either left or right and is not documented, you as the coder must select the unspecified site. Now let's talk about BMI, non-pressure ulcers, and pressure ulcer stages, and how to abstract the information and code it appropriately. Please note that BMI and pressure ulcer stages can be documented by a dietitian, a nurse, or any clinician that is involved directly with that patient's care. You can abstract the information in order to code BMI and pressure ulcer stages. However, the associated diagnosis such as overweight, obesity, or pressure ulcer must be documented by the patient's provider. If there is a if there's conflict information and documentation from different clinicians or the same clinician, it is always good to query for clarification. Also note that BMI codes should only be reported as a secondary diagnosis. As with all the secondary diagnoses, the BMI code should only be assigned when they meet the definition of a reportable additional diagnosis. Complication of care. Oftentimes, patients may have complications due to surgery or due to a procedure. So anytime there's a complication and it's documented, and the cause and effect relationship is there and it's in the documentation, you can code based on that. If a patient has complications and you cannot determine the cause and effect relationship in the documentation, it is appropriate at that point to query the provider for clarification if the complication is not clearly documented. Signs, symptoms, and unspecified codes. As mentioned earlier, if a definitive and/or confirmed diagnosis has not been established during that encounter, it is appropriate to code or report the signs and/or symptoms in lieu of the definitive diagnosis. Unspecified codes should be reported when they are the codes that most accurately reflect what is known about the patient's condition at the time of that particular encounter. That concludes the presentation as it relates to general guidelines for ICD-10. Please always refer to guidelines in order to know how to code, what to code, and when to code. If you have any questions, feel free to contact me, and have a great day.